So in the previous class we discussed about tonsillectomy surgery and septoplasty. So the third important surgery for you will be tympanoplasty. So in your final exams for your practicals, you will be getting three cases. The first one being chronic tonsillitis, and in that case, you will be asking questions related to tonsillectomy, the surgery procedure, and all things related to tonsillectomy. And the second case will be deviated nasal septum, and the surgery for that is septoplasty, and you'll be asked about that. And the third important case is chronic suppurative otitis media. Okay, safe type, that is tubotympanic type. So the surgery, the previous to the septoplasty and tonsillectomy have been discussed in the previous class. Now we are going to discuss about the third surgery, that is tympanoplasty. So this surgery is done for cases of chronic suppurative otitis media, safe type, that is tubotympanic disease, mucosal disease. So what is this tympanoplasty? First, if you see this picture, this is a picture showing an intact tympanic membrane. So this is an intact tympanic membrane with a handle of malleus, umbo. hmm, This is anterior malleolar fold. This is a posterior anterior malleolar fold and the posterior malleolar fold, and this is the cone of light, and this is the mild sagging of the anterior external auditory canal. So this is the normal tympanic membrane. So in cases of chronic suppurative otitis media, mucosal type, safe type of disease, the patient will complain of hard of hearing because of the perforation in the tympanic membrane. So if you see this picture, this is a perforated tympanic membrane. See this? This is the entire tympanic membrane, and this is the perforation, that is a hole seen in the over the tympanic membrane. And this is a central tympanic membrane perforation, and this is a marginal perforation. If you see this, the pars tensa is involved here, and there is an intact rim of the tympanic membrane all over surrounding this perforation. So this is a central perforation, whereas here it is involving the margin of the tympanic membrane. So this is marginal tympanic membrane perforation. So this, the tympanic membrane is either marginal or central, and we have to mention which quadrant. You all know tympanic membrane is divided into four quadrants: anterior inferior, anterior superior, posterior inferior, and posterior superior quadrants. And the size of the perforation should be mentioned, that is small, pinhole, small, medium, large, subtotal, and total perforation, that should be mentioned. So coming to a brief discussion briefly about this tympanoplasty. So this, what is this tympanoplasty mean? It is repair of the tympanic membrane with inspection of middle ear and possible ossicular chain reconstruction. So mostly this will be, it is also known as myringoplasty. Myringoplasty means repair of the tympanic membrane. So you repair the tympanic membrane by closing the perforation. And you use the word tympanoplasty when you also do some reconstruction or ossicular chain reconstruction in the middle ear. So indications for this will be to prevent recurrent disease and to improve hearing, to provide a dry ear canal, and enable patient to bath and swim freely. So this tympanoplasty, the appropriate candidates will be if the patient is having perforation of the tympanic membrane, and sometimes this cholesteatoma or any other lesions involving TM, tympanic membrane, or tympanic cavity, you need to do tympanoplasty. And in cases of resolved otorrhea, preferably no eustachian tube dysfunction. Okay, when there is a otorrhea, you should not operate, and when there is chronic eustachian tube dysfunction, you should not operate, because the middle ear aeration should be maintained. It is only well maintained when there is a proper eustachian tube functioning. So when there is no eustachian tube functioning, Even if you repair the tympanic membrane, the middle ear pressure is not maintained, and then again the tympanoplasty surgery becomes failure. So the poor candidates for this tympanoplasty will be multiple failed attempts at closure, if in patients with poor eustachian tube function, and in smokers and systemic diseases like diabetes mellitus and steroids use, and actively discharging ear or actively draining ear, and any slag injuries. Okay, so this there is so the word tympanoplasty means repair of the tympanic membrane. So what you want to repair, you need to close the perforation of the tympanic membrane. So what are the common materials used to close the tympanic membrane? So you use a temporalis fascia. This is the most commonly used material. The next, the following other most commonly used are perichondrium, cartilage, and periosteum and allodynes. And techniques of tympanoplasty would be underlay technique and overlay technique. So in this underlay technique, you place the graft medial to the annulus, whereas in overlay technique, you place the graft lateral to the annulus. Okay, and mostly you do for the most commonly used procedure for this tympanoplasty is, there are three different types of procedures with which you do this tympanoplasty. The first one being transcanal, the second one is a post-auricular, and the third one is endoral. The most commonly used performed one is the post-oral incision, followed by transcanal and endoral incisions. So this underlay technique, in which the graft is placed medial to the annulus, that is done mostly in cases of posterior central perforations or small central perforations, and any perforation with intact annulus. Okay, we'll discuss the procedure in the next. I'll show you a video. So for any underlay technique or overlay technique, there are some post-operative care things that a patient should be take care. That is, ear should be dry. It should not become wet. That is, the patient should not go for swimming, or the patient should not have uh, ears open while having bath. He should place some cotton or cotton plugs in the ear before going to bath. And that nose should not be blown hardly, and patient should avoid heavy lifting for 2 to 4 weeks, and antibiotics should be used in case of any infection, and antibiotic ear drop should be given, and follow-up will be after 1 week. That is, if there is any pack in the external auditory canal, you need to remove it, and after 1 month you have to clean the ear. Okay, that is about the follow-up. And in overlay technique, the selection of the patients will be marginal perforations, total or large perforations, who need canalplasty, and previously failed tympanoplasties. Okay, the procedure we'll discuss in the video. And the same post-operative care for both underlay and overlay. The ear should be dry, no nose blowing or heavy lifting for 2 weeks, follow up for up to 6 to 8 weeks, and drops after packed removal. So what are the complications of tympanoplasty? Persistent or recurrent perforation. So sometimes when you even operate the case, again it can become a failure. Again the patient will complain with history of ear discharge, or again the sign will be perforated tympanic membrane. That is recurrent perforation or persistent ear discharge. The second one is complications could be a cholesteatoma and dysgeusia, blunting of the blunting and lateralization of the graft, and sensorineural hearing loss or vertigo can occur, and sometimes facial nerve injury or caudal tympanic nerve injury can occur. These are the complications of tympanoplasty: lateralization, blunting, and they can ask you about what are the types of tympanoplasties. Woolstein in the year 1956 described these types of tympanoplasties: type 1, 2, 3, 4, and 5. In type 1, the ossicular chain is intact, that is simply called simple tympanoplasty, or also called myringoplasty, where the graft is placed over the handle of malleus. Okay. In type 2, the incus and stapes are intact, whereas the malleus is eroded. Therefore, the tympanic membrane is placed onto the incus, that is called incudopexy. And in type 3, there is incus and malleus both are eroded. In this, there is a mobile stapes superstructure. Therefore, the tympanic membrane is kept over the suprastructure of stapes. Okay, and in type 4, footplate of stapes, the intact the tympanic membrane, the graft is placed over the footplate of stapes because there could be an eroded stapes superstructure. And in type 5, it is in type 5a, that is called fenestration technique, also known as fenestration of horizontal semicircular canal is placed, and the 5 is stepidotomy, okay, with open footplate. So these are the types of tympanoplasties. And for conclusion, there are multiple techniques for tympanoplasty. The best should be selected based on the perforation and patient condition, and a healthy graft should be taken. Okay. So this is about in brief about the tympanoplasty. Now I'll show you a small video of tympanoplasty. You can understand. You Many examiners will be asking you questions related to this tympanoplasties. So if you see this video, so this is a perforated tympanic membrane with subtotal perforation. So this is a case of chronic suppurative otitis media, tubotympanic type or a mucosal type, safe type. So here this is the tympanic membrane perforation, central perforation, because there is an intact rim of the tympanic membrane all around the perforation. And if you see this is the handle of Malleus, which is retracted handle of Malleus, and this is everything the mucosa of the middle ear. So what you need to do, this perforation should be closed. So how you do that? So as you all know, this is a chronic disease, as the name indicates, chronic suppurative otitis media. And because if it is a chronic disease, the tympanic membrane perforation is covered with a squamous epithelium, squamous lining. So because of that squamous lining, the tympanic membrane doesn't close, that perforation will not be closed. So what you need to do, you have to remove the squamous epithelium which is present along the entire rim of the tympanic membrane. So that procedure is called freshening the margins of the tympanic membrane. So you see before this, you need to infiltrate the ear. This surgery is done under local anesthesia or general anesthesia. Most preferably you do it under local anesthesia. So you have to infiltrate all around the ear. Then you have to infiltrate with with local anesthesia, that is lignocaine or xalocaine, in the external auditory canal, so that the every ear will be sensation, the pain sensation will be lost, so that you can do it under local anesthesia. So you see this step, the surgeon is trying to remove the squamous epithelium. This is the squamous epithelium being lined over the perforated tympanic membrane, so that we need to remove it. So this step is called freshening the margins of the tympanic membrane. You see that? So after that, that removed part, that rim of the tympanic membrane perforation should be removed. So then you get a fresh margins of the tympanic membrane, right? So that fresh margins can again grow, and that will cover over the material which acts as a scaffold beneath your, just behind your tympanic membrane. So that material, the graft material which you are placed, should be placed behind this perforated tympanic membrane, and that graft material is used as a scaffolding material for the tympanic membrane squamous epithelium, this tympanic membrane, to grow again. Okay, so you see this, that the surgeon is trying to. So now this is the second step. After the freshening the margins, then you have to elevate a flap, also called as tympanomeatal flap. So what is this tympanomeatal flap? So you have to place the graft. So before placing this graft, you need to elevate. You all know that the extra aortic canal, there is a skin, right? That skin should be elevated from the bone which is present in the extra aortic canal. That should be elevated from the underlying bone, so that the graft should be kept from below this tympanomeatal flap. You see this? This is an incision which is being given to elevate the tympanomeatal flap. See, this is the bone, underlying bone, and this is the flap which we are trying to elevate. This is the tympanomeatal flap. and the incision which is given is called Rosen's incision. So this entire bone, the flap is elevated from the external aortic canal, and the flap is elevated up to the level of annulus, and even the annulus should also be elevated. So now the surgeon is trying to elevate the annulus also. So that is the annulus, and now we have entered into the middle ear. So you see this space, this is the entire middle ear, and this is the graft which we have elevated, flap, tympanomeatal flap which we have elevated, and this is the bone, and we have entered into the middle ear, and this is the tympanic sulcus from where the annulus have been elevated. And if you see that bone, this is the handle of malleus. You have to clear all the secretions or any liquid, sterile liquid which is present in the middle ear cavity, so that the middle ear cavity should be maintained dry. That secretions, anything blocking the eustachian tube or any spaces should be cleared. The disease should be cleared from the middle ear. And you see, this is the handle of malleus, skeletonization of handle of malleus. That is, any mucosa present over this handle of malleus should be removed, and the bone should be clearly visible, the handle of malleus, because the graft which you are placing, you need to place it over this handle of malleus. See, that is removal of the skeletonization of the handle of malleus. You have to remove the mucosa or any fibrous tissue which is present over the ossicles. And you have to note down the movement of the ossicular chain. The malleus, incus, and stapes should be mobile. If there is any ossicular chain defect, then you need to reconstruct ossicular chain prior to this maryngoplasty. Okay, and if the ossicles are clear, see, if you see this, you can see the malleus. This is the malleus, this is the incus, and here is the stapes. So this ossicular chain should be intact for a successful tympanoplasty to be performed. Okay, so this is the elevation of the tympanomeatal flap followed by skeletonization of middle ear ossicles, and then clearing of all the fibrous bands or tags present on the ossicles, and removal of the any secretions or fluid from the middle ear. And then you need to place a graft material. In the previous slides we discussed what are the various types of graft used to for tympanoplasty: temporalis fascia, perichondrium, cartilage, venous vein graft, or anything. So this entire middle ear cavity clear after removing all the disease and all the adhesions fibrosis. So this is an endoscopic tympanoplasty. The post-oral tympanoplasty and the endoral tympanoplasty are different, and for the clear picture of the surgery we are showing you the endoscopic or transcanal tympanoplasty. See, now the surgeon is trying to see the ossicular chain mobility. So if you touch the malleus, he is trying to move the malleus. That shows the movement of the incudo-malleolar joint followed by movement of incus, and then incudo-stapedial joint, and then the stapes. See, this is mobile, and here also it is mobile. And then you can wash the middle ear cavity with pure saline. so that if there is any cotton fibers or any disease or any fluid, that will be suctioned out and the medullary cavity is maintained disease free before placing a graft. So this anterior most opening is the eustachian tube orifice. Okay, can you see this? This is the eustachian tube orifice present in the superior aspect of the anterior tympanic wall. So any secretions in the eustachian tube should be cleared. And this is the what the surgeon is trying to keep is a gel foam, that is an absorbable gelatin foam which should be placed in the medullary cavity for the support of the graft which are placed, because medullary cavity is entirely air filled and if you just place a graft that can cause medialization of graft. So what you need to do, you have to support the graft medially and laterally with the help of absorbable gelatin foam. And now this step is most important. The surgeon is trying to keep a graft. This is a temporalis fascia graft which should be placed in the just medial to the malleus. So this is an underlay technique. See this is a graft which the surgeon is playing, trying to keep it medial to the hand of malleus. Then again a gel foam should be taken and placed over the graft. Okay, and then the extraordinary canal should be packed with gel foam. So this is tympanoplasty. Clear? So you may they can ask you any questions regarding this tympanoplasty surgeries and you should be able to tell everything. So the steps being, after anesthesia, the patient after in supine position, operated ear being upwards, facing upwards, freshening the margins of the tympanic membrane and elevation of the tympanomeatal flap, and skeletonization of the handle of malleus and removal of any secretions, fluids or fibrosis in the middle ear or any um, sclerosis, retinosclerosis, everything should be removed and then place the graft either in overlay technique or underlay technique. So this is about temporal tympanoplasty surgery. And the next surgery being for you most important one is the mastoidectomy. So when the patients with this mastoidectomy, so mastoidectomy is the surgery which is being performed for chronic mastoid disease. So the patient, if some patients are having chronic mastoid disease, you need to excentrate the cortex of the mastoid. The mastoid air cells should be excentrated and the mastoid should be made disease free. So that indications for this removal of the cortex of this mastoidectomy, that is called cortical mastoidectomy. The indications are being coalescent mastoiditis and mastoiditis, active refractory to antibiotics, and secondary otitis media refractory to antibiotics. And for other surgeries, we need to do cortical mastoidectomy prior to doing that surgeries. Those surgeries involve endolymphatic sac surgeries, facial nerve decompression surgeries, vestibulocochlear nerve section surgeries, translabyrinthine approach for CP angle tumors, cerebellopontine angle tumors, cochlear implant surgery, and combined approach tympanoplasty surgeries. So the indications being unresectable disease, unreconstructable posterior canal wall, and failure of first stage canal wall up procedure because of poor ET tube function and inadequate follow-up. So these are the indications for mastoidectomy. And relative indications being disease in only hearing ear or in a dead ear, medical illness, severe otologic or CNS complications, neoplasms, and poor eustachian tube functions. And the contraindications for mastectomy being chronic otitis media without cholesteatoma, acute otitis media with coalescent mastocytosis, persistent secretory otitis media or chronic allergic otitis media, and tuberculosis otitis media. These are the contraindications of mastectomy. So operative technique, I'll show you a video, and the brief about that is preparation. That is, this should be mostly performed under general anesthesia, okay, without any paralytic agents, and if possible, a facial nerve monitoring should be kept in the operation theater bedside, and an incision should be given, that is a post-oral incision should be given, post-auricular incision. But before giving that incision, you need to infiltrate with an anesthetic agent, that is lignocaine or xylocaine, 1 in 1 lakh, to provide hemostasis and local anesthesia. And then, so this is the surgery being shown. The surgical site is prepared and draped. The post-auricular incision is made from helical rim to mastoid tip approximately 1 centimeter posterior to the sulcus. Care is taken to avoid making an incision in the sulcus, and that can make closure more difficult. You see this is the incision for mastoidectomy, post-oral incision, 5 to 8 millimeters. A T-shaped incision is made in the mastoid periosteum to expose the mastoid cortex, and an incision is made along the linea temporalis to the level of underlying bone, and a second periosteal incision is made perpendicular to the linea temporalis and is carried down to the mastoid tip. You see this? This is the mastoid. The entire mastoid skin, periosteum, soft tissue, everything is elevated. So this is a musculoperiosteal flap being elevated for the mastoid. And for this mastoid bone, once it is exposed, you need to place two sets of self-retaining retractors perpendicular to each other to expose the mastoid and external canal. The complications for this mastoidectomy could be, most important complications will be trauma to the dura, okay, horizontal semicircular canal fistula, trauma to facial nerve, sigmoid sinus and jugular bulb injury, and postoperative infections. So these are the most important complications, because the mastoid, if you remember the anatomy, the mastoid is superiorly, it is limited, bounded with the dura of the middle cranial fossa. So if you go beyond superiorly, if you drill more, you can land up into dural complications. And medially of the mastoid cavity, you get this horizontal semicircular canal. So when you drill more into the medial cavity, then you land up into creating a fistula of this horizontal semicircular canal. And then the facial nerve is an important nerve present in the medullary cavity, and if you go very more depth, or if you are not knowing the proper facial nerve course and anatomy, then you can land up into trauma to the facial nerve that can cause facial palsy. And sigmoid sinus, that is located in the posterior aspect of the mastoid, posterior superior aspect, and then the jugular bulb, these both can get injured. And if you are not treating properly, post-operative antibiotics, if you are not placing properly, then that can lead to post-operative infections. Okay, so now we'll see a surgery of this mastoid. So if you see this, first let me show you some this animated video where you can get a clear picture of the anatomical structures. See, this is the auricle, and this is the post-oral region, and this is the mastoid bone. Okay, so this is a post-auricular sulcus. Okay, so your incision should be in the post-auricular sulcus. Okay, so retract the ear anteriorly and then put an incision in the post-auricular region in the post-auricular sulcus, and then you have to retract the skin, subcutaneous tissue, and then the periosteum present over the mastoid bone. So if you retract this everything, then you will be able to see this mastoid bone cortex of the mastoid. And this is the external auditory canal. After retracting the skin postauricularly, you will be able to see the postauricular canal. Okay, then you have to. So this mastoid bone is infected. So what you need to do? This mastoid air cells should be exonerated. You have to remove all the air cells to look for any disease or mucosal disease or any cholesteatoma or anything. So you have to drill this. So see, this is a mastoid. After drilling, you get all the vital structures. Here the superior border being the dura, here posterior aspect being the sigmoid sinus, and inferiorly you get the jugular bulb, and just below this posteriorly you get the facial nerve and the chorda tympani nerve. Okay, so be careful while operating. You can get the dura here, sigmoid sinus, jugular bulb, facial nerve, and chorda tympani nerve. So after you drill for some time, then you land up into the middle ear. That is the largest air cell is exposed, is open. That is the antrum of the middle ear, the mastoid. The mastoid antrum is open. So by opening, entering into the mastoid antrum, you get access into the middle ear cavity. So okay, this is the drilling of the mastoid bone. So you see this. This is the mastoid antrum, which is drilled, and then after opening this mastoid, entering into the getting access into the mastoid antrum, you see the body of incus, second bone, that is the incus is seen, and this is the semicircular canals that you get. Okay, horizontal semicircular canal and the posterior semicircular canals can be seen. And then this is the sigmoid sinus, that is the chorda tympani nerve, that is the facial nerve, and that is the middle ear ossicles. Okay, incus, body of incus, long process of incus. It's a facial nerve and the chorda tympani nerve. Then still if you drill, you can see the stapes also. This is the malleus, this is the incus, and this is the stapes. All the ossicles can be seen by drilling the mastoid. And this is the lateral semicircular canal, and this is the posterior semicircular canal, and the round window can be exposed. So if there is a case. So postoral incision is given after infiltration. Postoral incision, the skin, superficial subcutaneous tissue, and mastoid periosteum is exposed, and then we have to retract with the help of retractors, and then start drilling with the help of drilling machine and drill bits. So that is the entire cortex being drilled to enter into the middle ear cavity. So that is the entire drilling of the mastoid cortex. So you have to give proper irrigation to while drilling the mastoid. Okay, to prevent heat damage and burning of the tissues. See this? So continuous irrigation with saline is very important while performing mastoid surgeries. This is the antrum being opened, and this is the posterior tympanotomy being done. This is the facial nerve. So this, if there is any disease in the medullary cavity, you have to remove. Like any disease like cholesteatoma or any debris and all. Mucosal edema thickening. So this mastoid exposure, postoral mastoidectomy is done to remove a wide extensive diseases of the mastoid cavity. And in very huge cases, you do a this is a canal wall down mastodectomy. You need to remove the posterior auditory canal, posterior cavity by doing canal wall mastodectomy to get a single huge cavity to make the mastoid cavity huge, single, and disease free. Okay, so this is the tympanic membrane. You remove that, you can make the entire mastoid cavity into a single cavity. Okay, this is a total complete mastodectomy, and again you suture it. So this is the surgery of mastoidectomy. So these questions they can ask you in practicals. So remember, read about tonsillectomy, septoplasty, and tympanoplasty and mastodectomy very thoroughly. Okay, thank you.